Good afternoon, everybody. This is Arifa from Toronto, and I thank to the technology. I do have my guest all the way from England with us. Dr. Anthony Leeds is conducting these programs for some time. I thank him very much. And these are the core medical issues, that is obesity and diabetes. Along with that, we spoke and he talked about other sicknesses as well, which is sleep apnea and then osteoporosis as well. Of course, I thought diabetes is mother of all the sicknesses, but now I realized after all these programs with Dr. Anthony that mother of all sicknesses is weight gain or obesity. And of course, these days our habits, our food style, our lifestyle, it all contributes towards the weight gain. We are very lucky to have a wonderful doctor with us, and I thank Dr. Anthony for arranging that, and that is Dr. Dimitrios Pournaras. Did I pronounce right?
Very good.
Okay, so I'll say Dr. Dimitri. Okay. He sounds like a very happy camper. He looks like a very happy camper. Dr. Anthony, I thank you very much. And of course, you are the main person who's going to talk about this. When I talk about Dr. Dimitri, whatever I got is he graduated from Aristotle University, Greece, and then all post-graduation from the UK. He was awarded research fellowship by the Royal College of Surgeons of England to conduct research on obesity, diabetes, and metabolic surgeries. He completed his PhD after medicine. He completed his PhD in the Department of Investigative Medicine. And of course, he is trained as laparoscopic osteogastric. Doctor, you correct me for that. What is that? So all kind of research.
Stomach and the gullet is where I operate on. You've been very kind with the introduction.
Thank you very much. But I am very much impressed, and I wish I can come to England. He is multi-modal care, laparoscopic, gastrointestinal surgeries, management of gallstone, जिसको हम पित्ता कहते हैं, पित्तर में बाज़-औक़ात पथरी हो जाती है, उस पथरी के इलाज के हवाले से, and gastroesophageal reflexes, जिसमें food जो है वो ऊपर की तरफ आती है. So it's a combination of Urdu and English. Dr. Anthony, I wish you should start understanding Urdu as well, because my listeners, they need you to speak Urdu.
Okay. That's perhaps for the future.
Inshallah. God willing.
Okay. Yes. Okay.
Yes.
Well, thank you very much indeed. And thank you, Dimitri, for taking the time to come and talk to us this afternoon. As you know, we've been talking about obesity, people with obesity, and also the major problems associated with obesity. And as you know, previously I've talked, for example, to Michael Lean about the diabetes remission trial, which was run in Glasgow and Newcastle. But of course, we're all aware that there are different ways of approaching helping people who have obesity, and one of the important ones, particularly in relation to diabetes, is bariatric surgery. So we thought it would be a very good idea to actually discuss some of the detail for the benefit of this audience. So perhaps we could begin by explaining exactly what is bariatric surgery and how it can be beneficial to some people.
Thank you, Tony. And I'll say that next time, hopefully I'll be describing this in better Urdu, but my Urdu is very poor at the moment. So in an attempt to discuss this in English, what the surgery does, it is about weight loss and weight loss maintenance. And I know you discussed this with Mike Lean last week. The challenge is this weight loss maintenance. I very often get asked about how do these operations work. And I think that the easiest way to discuss this is to think a bit about how we all eat. Now, most of us, after a meal, at some point we stop eating and we all feel full. And that's the words we use. But that's not true. Because if I offer you your favorite drink after a meal, you will drink it and your stomach will not explode. It's a message from the gut to the brain that tells us that we feel full. And that part of the brain is the bit that we cannot control. It is the same part of the brain that does the breathing. And just like we cannot talk ourselves into stop breathing, we cannot talk ourselves into losing weight. Or even if we do that, it is very challenging. We do know that people living with obesity have weaker signals between the gut and the brain. And that's what surgery comes into play. By doing keyhole surgery in our stomachs and in the gut, we can change the signaling and make it stronger. Therefore, our patients can eat smaller amounts and feel full earlier. And that gives us our weight loss and, more importantly, our weight loss maintenance. If you want to be philosophical about it, we always talk about the obesogenic environment. And if we cannot change our environment to change the disease of obesity, we can change the way we perceive the environment. And the way all of us perceive the environment is via our gut. Yep. So what I do and what a lot of us do with surgery is we're changing this signaling.
Yeah. And so the consequence of that is what for specific individuals with weight-related problems?
So straight after surgery, people will start feeling less full. So feeling less hungry and feeling full earlier on. So you start getting weight loss in the first few weeks. In terms of diabetes, we see a dramatic improvement in diabetes, and that happens by changes in insulin resistance. So insulin resistance drops, and some of it is mediated by the reduced food intake. And I know we've seen that with studies similar to the work you have done. We see a dramatic reduction in insulin resistance, and at the same time we see an increase in insulin production. And that happens within a day or two after surgery. We measure that straight away, and that seems to be proportional to food intake. So insulin production is you get that flat insulin production that you get with diabetes. You get the supraphysiological peak in people both with and without diabetes. But of course, it's people with diabetes, with type 2 diabetes, that we see this profound change. So that happens in the first few weeks. And I should say that people after this sort of surgery go home within a day or two. In most units around the world, within 23 hours. The majority of them go within 23 hours in the hospital I work in. And then weight loss continues. And the weight loss maintenance continues. The weight loss plateaus at about 18 months to 24 months, within a couple of years, and then we have stability of that weight. And of course, at that time, we're starting to get the improvements in the obesity-associated disease. And we all heard earlier on that it's not just about diabetes, it is about all these obesity-associated diseases. Hypertension, so people with high blood pressure, that is reduced. Gastroesophageal reflux gets improved. Sleep apnea improves, and a lot of our patients can now stop using the sleep apnea machines. Not everyone, but a lot of people. Mm. And of course, function improves. And it is not about, as I always say, and you and I have discussed this many times, it is not just about kilos, and it's about weight loss. It's about improving people's function. And we do see improvement in their ability to walk. We see improvement in musculoskeletal pain. People who live with arthritis can, and particularly osteoarthritis, we can see an improvement very early on. And a lot of our patients will still need to have orthopedic surgery for joint replacements, but that is now a lot safer. So it is a variety of factors. I should also say that even employment changes, and we do see people who were not able to work can now work, or they can longer hours, so they can improve the job prospects. We see this in such a variety of targets.
Yeah. Now, from all you've said, it would suggest that the numbers of individuals who might well benefit would be rather a large proportion of the population. So how do people get to the point where they're able to access surgery? And also, to some extent, how do we select individuals? For example, in diabetes, is it best to select people early on, when just after or soon after diagnosis of diabetes, or later on? Is it beneficial for people who've had diabetes for 10 years, for example?
I think it's important to acknowledge that most people who could benefit for surgery do not get surgery. So I'm just going to give an example for the UK, that if we double the amount of surgery we do in the UK every year, this year we will still be operating less than 1% of the population that could benefit from this type of intervention. So the reality of it is that most people do not have access to that. It does not get offered to them, and that belongs to the healthcare system, the whole landscape, if you like. And from those people who it is offered, most people will not want to have surgery, because most of us do not want to have surgery if we can avoid that. And from those people who want to have surgery, then a very robust and thorough selection process works by a multidisciplinary team. It's not just a surgeon and a patient, but it is that physicians are a key part of this, dietitians, psychologists, working in a multidisciplinary team with input from other specialties across the board. And then a number of these patients do have surgery. I think it's important to also highlight that obesity is a challenging disease to treat, and type 2 diabetes is a challenging disease to treat, and we need multiple options for different people. I don't think it's one size fits all. It's not one treatment that's going to be the cure for everyone. People need to have a variety of treatments, and those treatments may work in some people. And what I really want to say today is that the response to the treatment is a biological phenomenon. And we accept this for a lot of diseases outside obesity. So, for hypertension, you know that if I tell you that my systolic blood pressure is very high, you will try a number of tablets, and eventually, you'll get to a combination that really works for me. And how much I want this, how motivated I am, is never part of this equation. For obesity, we do this all the time. So any treatment, and I would say that surgery is probably the higher risk surgery. Is more dangerous than other treatment. It's still very safe. It's still safer than not having surgery in terms of the risk of obesity. But also, high benefit. We do see a larger amount of weight loss and weight loss maintenance. But it's important to say there are people who will not respond to surgery, and that is not their fault. That's a biological phenomenon. Just like we give people cancer treatment, and some people do not respond to therapy, and some others do. I think it's important to highlight that.
Yeah. How good are
Dr. Anthony, I'm sorry, I have
yes.
a question over here, Dr. Dimitri. Now, as you said that most people who need this surgery, they don't go for. But my question and concern is obesity is the main thing which causes heart conditions, diabetes, and all other conditions, hypertension, which is a burden on the system. Why people like yourself and others and the system does not educate people how important it is to think about this option, number one. Number two, should they go directly to some bariatric surgeon, or the family doctor should guide them that this thing or this surgery can change their life and bring good things in their life? So this is a second question, and my third question is sometimes the education part, they should educate them that what are the side effects linked with this bariatric surgery. Yes, now please respond.
So that is I'm going to go systematically. I'll start with the first, and I will say that I think the responsibility lies with all of us. For a long time, we did not have the data that surgery was safe and effective. We now do. We now know that surgery is very safe. It's one of the safest operations we do, and we do know this outside clinical trials. It's important to say that it is done safely when it's performed by surgeons who are trained in this, who perform this in high volume and high frequency in institutions with a multidisciplinary team that have experience in this. This is not the surgery to be done once every few months. This is a surgery that needs to be done really high frequency because it's highly specialized and the stakes are high. I think that we all have a duty to increase access to this type of surgery, and it is not about educating patients or clinicians or healthcare professionals, policymakers, health managers, healthcare providers. It is about all of us working together and identifying the need and then working in a way of meeting that need by collaborating across the board.
Do you think it's likely that in the light of the recent evidence over the last 15 months that being overweight and having obesity and diabetes actually increases risk in relation to the COVID-19 pandemic, that there might now be a response from policymakers and governments, ministries of health across the globe in relation to recognizing that among all the other interventions that you can do for weight, that we need to see more bariatric surgery. So the last figure I heard for the comparison between Britain and Sweden was that in Sweden, per head of population, they do 9 times as much bariatric surgery as we do in Britain, which is an extraordinary difference of proportion.
I completely agree, Tony. I think I'm embarrassed to highlight that figure, and that's why we're working in the UK trying to improve access here.
Yeah.
But also at the same time we're doing this in the UK, I think we should try to do it around the world. And I know that Pakistan is a focus for our audience and other parts of Asia, and there's a desperate need to do that as well. We cannot wait to sort this in the UK and then go elsewhere. We have to go around the world. I think this is the right time to understand the impact of obesity on all diseases, and it turns out that COVID-19 is not an exception. And I can share some data that is not published yet, but we looked at modeling data in terms of doing bariatric surgery during the pandemic. We already know actually from real life data, there has been no deaths in the UK from COVID-19 in patients who underwent bariatric surgery during the pandemic. Mm-hmm. I think that shows a lot. And also there has been no death from a very large study in 38 countries, more than 140 hospitals. Again, not a single death from COVID-19 during the pandemic. This is real life data. In terms of looking at the impact of that, we know that we could reduce hospital stay, we could reduce ICU stay from COVID-19 only, we could reduce mortality from COVID-19 only, in addition to the cardiovascular mortality, if we did more bariatric surgery.
Yeah.
So I think it's the right time, and I think this question has to be asked to policymakers and planners around the world.
My question over here is, normally a person like myself is direct contact with the GP. Now, if a person in contact with the GP has all these conditions, because we don't directly deal with the specialist like yourself, so is it not the GPs they should recommend to go for these surgeries because they are the referral people?
So I'm going to answer this because I owe you two responses. So I think we've dealt with question number 1, but question number 2 is, and going to who should be referring that, I think everyone. I think working with the GPs is essential. Most of our referrals come from GPs, but also quite a lot of our referrals come from other hospital specialists. So the cardiologists and the renal physicians and the respiratory physicians directly referring to us. And I think for our audience, for individuals living with overweight and obesity, I think a discussion with the GP with a clear request or clear request for information is the way forward.
Yep. Can I just ask another question? Because people listening will be asking, do people who are considering surgery need to make any preparations beforehand? And then afterwards, is there a long-term management program? Do they have to have checks on an annual basis and so on? And do we have that in place effectively?
Absolutely. And that will also allow me to answer the third question as well, which is about the side effects. So this type of surgery is not emergency surgery. It is important surgery, and it's life-saving, life-changing surgery, but never an emergency. And therefore, it needs to be planned well. So there is a preparation process that can be lengthy. And that means that the whole multidisciplinary team need to make an assessment. We may need to treat people beforehand. We need to spend some time and effort preparing patients. And the way I'd like to say that is going back to what we discussed earlier on, this type of surgery changes appetite. And I'm saying that knowing very well that in Asian culture, as well as the culture where I grew up, food is a key component. Every time there's a celebration, there's food involved. Every time someone comes to someone's house, there's food involved. So if I'm going to change the way someone is eating for the rest of their life, they need to be prepared for that. And that is a key part. So I also think that very often we can reduce the risk of surgery, and I should say that the risk of surgery in large series would be less than, in the UK, it's less than 0.1%, less than 1,000, the risk to life. We very often hear that this is dangerous surgery. It's actually very safe surgery, but it can be reduced further by some preoperative weight loss. And we also know that, and I do that part of my routine practice, most of our patients will also have a very low energy diet in the 2 weeks before surgery to reduce the size of the liver and make the operation safer. It's also important to say that the side effects in terms of after surgery, there's a small risk of reoperation due to surgical problems. That is about 1%, requiring another operation. It can go up to 2%, but that's the sort of figures we're talking about. And then we need multivitamin tablets, lifelong, and follow up by a specialist team in the first couple of years. That's what we do in most centers around the world. But lifelong follow-up with regular blood tests, at least yearly, to look for vitamin levels and ensuring that the supplementation is working well. And that needs to be done by specialist teams. So it is a very well thought out process that we're talking about here.
Yep.
Dr. Anthony, sometimes in this system, living in Canada, a few things most of things are covered by OHIP, but if something is considered as cosmetic, that is not covered by OHIP, people have to pay from them. How it is being identified, is it life-saving surgery or is it a cosmetic surgery?
Not cosmetic. I am not a cosmetic surgeon, and the surgery I do in the stomach is not cosmetic. In fact, the cosmetic outcomes of this type of surgery are very poor, because after dramatic weight loss, a lot of our patients do get excess skin, and some of our patients really do not like what they see in the mirror. Their health has improved, their function has improved, but they may not like what they see in the mirror. And then they may ask for some cosmetic surgery. So this surgery is life-saving, life-changing. It is not cosmetic surgery. It is not considered cosmetic surgery by the people who do it. It is not considered cosmetic surgery by the people who receive it. And it should not be considered cosmetic surgery by the healthcare providers and healthcare politicians.
Thank you.
But one of the other things that we've talked about is the question that after 2 years, say, and a weight stability, that many patients would then be asking for cosmetic surgery. And in the pathways that are considered in some countries, it doesn't really follow through to an adequate capacity for delivering the type of perfectly reasonable cosmetic surgery that might be expected. Do you think that's a problem?
It is. I completely echo that, Tony. And I think that in the UK we have had this challenge, and I think it's important to highlight that. Of course, we're in the business of trying to save lives here and trying to improve people's health, but there are some cosmetic outcomes. I would argue that some of the patients you and I discuss very often have functional challenges because of excess skin. It is not that they just don't like what they see in the mirror. There is a challenge in terms of recurrent infections, in terms of the actual weight of the so-called apron, this excess skin that's in the abdomen. And I think that we need to think about that as a healthcare service. But I also think there's an opportunity here. And the opportunity is that for parts of the world where this service has not been established, it is important that when we're in the process of establishing this, they should be considered. So if we were discussing, and if any of our audience is considering building, for example, a service in any parts of the world which is desperately needed, I think that part of the service should also be considered and integrated early on, instead of being an afterthought, as it is often the case in established bariatric units around the world, just as it is in the UK.
Yeah. Everything we've said so far indicates very clearly that bariatric surgery should be more widely available, probably in almost all countries in the world. And one of the ways in which healthcare providers look at this is to do health economic analysis to see, is the cost of this going to deliver a benefit, a measurable benefit, which offsets other costs. And I mean, there is really rather a lot of good evidence for that, isn't there? And it's therefore difficult to understand why it's been so slowly taken up.
So I don't think it's I'm completely in agreement with you, Tony. I don't think this is a cost effectiveness data or lack of that. And actually, I find it sometimes quite upsetting that we have so much robust data that this is not only cost effective in the long term, it's actually cost cutting very early on. So most of the models say that within 4 or 5 years, it becomes cost efficient already due to the reduction in medication usage. And as a surgeon, and I have to say that a lot of the surgical procedures we do have not gone through the same level of cost-effective scrutiny. And I would argue for a lot of, and that doesn't mean we should stop doing it, but a lot of the surgery we do, which is highly expensive in the cancer field, and in transplant, absolutely essential. And for the individual who gets this surgery, you cannot put a price on life. But as a healthcare provider, I think it challenges us. And if I have to answer your question with honesty, I think it is about stigma. It is about the fact that obesity is not considered a disease. It is considered a patient's choice or individual's choice, or a lifestyle issue. And as long as we continue doing that, I think we will struggle to improve obesity care with all modalities around the world. We need to address stigma. I know that in Canada, there's a lot of work being done, which is world leading in this field. And I think all of us need to embrace that and challenge the dogma, the wrong dogma that obesity is someone's choice.
Yeah, absolutely.
Thank you very much.
Now,
very informative program, Dr. Anthony. We are, I understand, I think we should show some images to the people as well about this bariatric surgery. Thank you very much, Dr. Dimitri. What a wonderful information. This means, even though if it costs you, the last words were very important, that in the long run, it can save many other sicknesses, much more what we spend on the medicine, much stress on other sicknesses, and it will be a life savior as well. Thank you to both of you, Dr. Anthony Leeds and Dr. Dimitri. Thank you very much.
Okay, thank you.
Thank you.
Thank you. Thank you.
God bless you. I hope, and to be honest, I wish I can go and get something done. Because yes, if I am more mobile, I will be more efficient. Thank you very much for watching the program. Please do subscribe and log on to our website, which is www.eawaz.com. We'll come back with another episode. Till that time, God bless. Stay safe, stay blessed.